What's up, Ninja Nerds? In this video today, we're going to be talking about central Pontine Myelinolysis, also known as Osmotic Demyelination Syndrome, which we'll kind of refer to that throughout the video. All right, before we get started though, please continue to support us by hitting that like button, commenting down the comment section, and please subscribe. All right, let's get into it. All right, Ninja Nerds, so let's start off first talking about the etiology, pathophysiology of Osmotic Demyelination Syndrome. So first thing you have to remember is that generally in these patients, the cause is a very rapid overcorrection of the patient's sodium. So someone usually has a chronic hyponatremia, low sodium levels within the blood. And we'll talk about the conditions that can lead to that. But generally what happens is you overcorrect it. You try to correct it too quickly, and it leads to demyelination, destruction of those oligodendrocytes that myelinate the axons in the CNS, and leads to nasty clinical manifestations. So what are the conditions in which you can have chronic hyponatremia? Because these should be things that you think about. Oh, this patient has this low sodium. Well, why? Oh, they have this disorder. I should try to avoid correcting this too quickly. All right, so the first one that I want you guys to remember is cirrhosis. So how does cirrhosis really do this? Okay, cirrhosis is very interesting. In someone who has cirrhosis, they develop a very particular type of problem, right? So there's so much fibrosis of the liver that this hepatic portal system, right, here's your, let's call this your portal vein, it really struggles to be able to get blood through this portal vein, through the liver, and into your inferior vena cava, right? So this is your IVC, your inferior vena cava. So there's a high portal pressure, which results in less blood flow moving through the liver and decreased blood volume in your inferior vena cava. Now, why is that a problem? The reason why that's a problem is whenever you have low blood volume, because there's kind of like less fluid coming there, this happens to trigger the brain, particularly, you know, within the hypothalamus, there's osmoreceptors that pick up on the changes in osmolality and then tell your posterior pituitary to make ADH. Well, what happens is whenever you have these low blood volume levels, it triggers this small kind of increased release of ADH. ADH will then act on the kidneys. And what it'll do is it'll act on the kidneys to increase the reabsorption of, so it'll increase the reabsorption of water. And so we'll have more water within the bloodstream. Now, normally, you should have a nice kind of like equal mix of sodium and water. But what happens if you have more water, way more water, and you have less sodium to kind of balance out with that water? That can lead to kind of a dilutional type of hyponatremia. So this can present as hyponatremia present in a patient with cirrhosis. And usually this is something that they've had for a long time, but we kind of say greater than or equal to 48 hours as chronic hyponatremia, right? Because they've been having this for a while. So that's one type of cause. The second one is really weird, but it's kind of cool at the same time. Another condition that you want to be thinking about is if someone has hypokalemia. So hypokalemia is low potassium levels within the blood. Now, if there's low potassium levels within the blood, there's also going to be less potassium kind of in the cell. Okay, and the problem with that is you need to be able to kind of maintain somewhat of an electroneutrality within the cell. So potassium is a positive ion, right? It's a cation. So if there's less potassium within the cell, there's not enough positive ions in the cell. So instead, what happens is our body has a way of yanking sodium into the cell to counteract the low amounts of potassium in the cell. And if so we bring a lot of sodium into the cell, what happens to the sodium in the extracellular fluid? It drops. And so you result in a decrease in the sodium in the extracellular fluid, and this is called hyponatremia. And again, this usually has to be someone that it's a little bit more chronic in, greater than or equal to 48 hours. All right, so we got cirrhosis, we have hypokalemia. The next two is kind of a double whammy. This next one you can see in people who have severe malnutrition, so malnutrition, or they're an alcoholic, so we'll put ETOH. So how does this work? When someone is malnourished or they're an alcoholic, they're primarily drinking that's their sustenance. They're not really eating a lot of food. They're not taking in a lot of things that are usually going to contain salt or sodium in it. They're going to be drinking a lot of their things in the form of water or in the form of alcohol. If that's the case, then they're going to be reabsorbing or absorbing a lot of fluid. In this case, we're going to say that they're going to extract water from whatever fluid that they're drinking. It's not going to be food because, again, it's either they're guzzling alcohol or they're not eating any food. They're primarily only kind of drinking their actual fluids. If they're only taking in fluid, we're going to extract water from that fluid from the GI tract, right? So from the GIT, we're going to pull off water from whatever fluid that is consumed. Now think about this just in the same way as cirrhosis. We have water and sodium. We like to keep them in somewhat of a nice tandem. But if you're taking in too much water, more water than you actually have sodium within the bloodstream, what's going to happen? This is going to kind of lead to like somewhat of a dilutional type of hyponatremia, but it's hyponatremia nonetheless. So hyponatremia, and again, this has to be in somebody that it's been greater than or equal to 48 hours. So you kind of get the theme here that I've wrote across the board very consistently. Hyponatremia greater than or equal to 48 hours. That is classified as chronic hyponatremia. I'm going to put low sodium, right? Chronic hyponatremia is greater than or equal to 48 hours. Why is that important? And also we should kind of classify. A lot of our literature says that whenever these things are present, cirrhosis, hypokalemia, malnutrition, alcoholism, and a chronic hyponatremic, greater than or equal to 48 hours, and the sodium is recorded at less than 120, these are all things that you should think about whenever you are treating a patient, avoiding giving them too much, trying to bring their sodium up too quickly can result in this dangerous disease. Okay, so these are the big things I want you guys to remember. Okay, so again, cirrhosis, hypokalemia, malnutrition, alcoholism, and a chronic hyponatremic with a sodium less than 120, if they're greater than or equal to 48 hours, do not correct their sodium too quickly. But guess what? In some people, it gets corrected too quickly. What happens? All right, so we've gone over the etiological factors for someone developing a kind of a chronic hyponatremia, right? Now, what's really, really important to the pathophysiology is how the brain, particularly the astrocytes, adapt to hyponatremia. And they do this over a particular period of time. And that's why I've said this 48 hours. After about 2 days of someone having hyponatremia, their brain kind of adapts in a particular way to accommodate for that, to where it's not dangerous. Because hyponatremia can be a bad thing in the brain because it can cause cerebral edema. So how does these astrocytes adapt in a particular way? So the astrocytes will adapt in a particular way. So right now the problem is that there's low sodium outside the cell. So if there's low sodium outside the cell, that probably means that there's going to be a little bit more sodium inside the cell, so water will rush into the cell, causing it to balloon up, causing edema. We don't want that. So what our astrocytes do is something really freaking cool. What they do is they start pushing glucose out of the cell. So they start kind of pushing glucose and other types of osmotic solutes. So another one is like glutamine. They'll push like glutamine out of the cell. Anything that has kind of an osmotic activity to it. As you push things out here like glucose, as you push things out here like glutamine, these are osmotically active agents. They're going to yank water towards them. And so instead of water coming into the cell causing cerebral edema, what they'll do is the water will go outside. And just a little bit, it'll be enough to kind of bring an equilibrium between the two. So now if I bring water out here, that's going to help equilibrium-wise between the extracellular compartment and the intracellular compartment. So this process of adaptation occurs over a period of about 2 days. Now, after this occurs where someone has had time to take their hyponatremia and adapt, you go and say, oh, I saw that the person's BMP showed a low sodium. I got to correct this very quickly. I'm just going to blast them with lots of salt. And so you put them on certain types of saline solutions, maybe 3% hypertonic saline, or you give them just lots of 0.9% normal saline, whatever it is. You give them lots of salt. As you do this and you push lots of salt into their bloodstream, now the sodium outside of the cells is going to be very significantly high, right? If you try to quickly bring it up. As it does that, now the astrocytes will not have time to regenerate a new gradient like they did with the glucose. They don't have time for that. And so they go into this mode where, oh shoot, water is so appealed by all of that salt out there that it just decides to just escape the cell extremely quickly and extremely significantly without having a proper amount of time to regenerate the gradients between glucose and glutamine. If lots of water leaves these astrocytes, what's going to happen to the astrocyte? They're going to shrivel, and eventually this is going to cause some problematic issues. It causes two things. One is it causes the DNA to start to fragment as the cell starts to shrink. The second thing is it causes proteins to kind of stick together. They call it aggregation. So proteins start sticking together. And this eventually will lead to apoptosis of the astrocytes. These suckers die because of this process of water leaving them and causing them to shrivel up and leading to these processes. These cells will die. Why is that a problem? Well, the astrocytes are a very significant component of what aspect? The blood-brain barrier. They're one of the three components. If you lose the astrocytes, are you going to be able to have an intact blood-brain barrier? No, you disrupt the blood-brain barrier. And now more things can leak or move across the blood-brain barrier freely. Also, whenever these are actually damaged, it releases a ton of inflammatory cytokines. These inflammatory cytokines will stimulate microglia. And these microglia will lead to kind of an inflammatory reaction that leads to the destruction of the oligodendrocytes. As these oligodendrocytes become destroyed from all of this inflammation and microglia activation and gliotic process, they will undergo demyelination of those axons. As you demyelinate these axons, this will lead to particular neurological deficits in the areas that they most commonly occur, which is usually in the pons. So that's our etiology, pathophysiology. Let's talk about clinical features. What's up, Ninja Nerds? Had to make a little wardrobe change, but check out the Ninja Nerd Swagoo. You guys can get some down in the description box. We'll have a link there, so check that out. All right, so now let's talk about the clinical features of osmotic demyelination syndrome, right? So first things first, when we have this demyelination of these neurons, it primarily loves to occur within the pons. That's why we call it central Pontine Myelinolysis. But it can extend extrapontine demyelination. But think about the things that are located within the pons, but cranial nerve nuclei. Let that be the good one that you think about. What are some of the cranial nerve nuclei that you could actually demyelinate in effect? Well, think about the first one. This would be cranial nerve 5, the trigeminal nerve. If you injure that one, you're going to have weakness with chewing. Right? Think about the next one, is cranial nerve 6. This is the abducens nerve. And so this is involved in stimulating the lateral recti, right? So whenever these are supposed to contract, they're supposed to abduct the eyes. Now, if that's affected, particularly whenever you're looking at an image, it can actually cause double vision to form, right? So it can cause diplopia. All right, what's the next one? The next one is the facial nerve, cranial nerve 7. Now the cranial nerve 7 is actually involved with facial expression. So if you hit that one, you can potentially develop absent facial expressions. And the last cranial nerve here that we actually want to think about here is cranial nerve 8, which is kind of at the bottom at the pontomedullary junction. And so cranial nerve 8 is the vestibulocochlear nerve. But this one we want to be thinking about particularly the vestibular nuclei that could be affected. And so what can happen is they can develop a nystagmus. Not so much vertigo, but particularly they may develop some nystagmus. All right, so quickly, again, cranial nerves that I want you guys to remember. What are the cranial nerves that are located within the pons? 5, 6, 7, 8. If you hit those, you develop weakness in chewing, you develop diplopia, you develop absent facial expressions, and you develop nystagmus. All right, next thing. Not only can you hit these at the fascicles, particularly the fascicles of these cranial nerves, but you may also hit the tracts that are coming down to innervate those cranial nerve nuclei. So think about the particular tracts that come down from the cortex. So you're going to have the upper motor neurons located within the primary motor cortex, the premotor cortex, primary somatosensory cortex. All of these guys send their motor neurons that run down through the corona radiata, through the internal capsule, and then scatter and give stimulation to some of these cranial nerve nuclei, which are located within the pons, and even they go down and extend to the medulla as well. What are those fibers called? corticobulbar tracts. And so if you hit some of these corticobulbar tracts and you damage them, you demyelinate these axons, particularly when they're running through the pons, what can that lead to? That can potentially lead to a condition called pseudobulbar palsy. Now, with this condition, right, you're going to be having some of these overlap. Because again, go back to one of the actual first cranial nerves that is actually innervated by the corticobulbar tracts. This is cranial nerve 5. If you injure cranial nerve 5, or particularly you don't provide stimulation to cranial nerve 5, what's going to happen to the chewing muscles? They can develop weakness with chewing. Super simple, right? It's kind of like we're going to repeat what we just did over here. What about the next one? The next one is cranial nerve 7. It also receives stimulation from the corticobulbar tracts. If you injure the corticobulbar tracts, you don't stimulate this nerve, you can develop absent facial expressions. And then the next one is, what if we actually have no ability to stimulate this next one, which is the nucleus ambiguus? You know, the nucleus ambiguus is responsible for leading to the stimulation of cranial nerves 9, cranial nerves 10, and even a teensy little bit of cranial nerve 11, the accessory nerve. Whenever this is injured, or you actually don't supply these actual cranial nerve nuclei via the nucleus ambiguus, these are responsible for stimulating the muscles that are involved in speech, right? So, you know, there's actually muscles that are particularly like the larynx and even parts of the pharynx, as well as for swallowing, like muscles involved particularly within the pharynx and even the esophagus. If those are not actually going to be stimulated, these cranial nerve nuclei are not stimulated, you won't have proper ability with speech. And what is that called? Whenever there's inability to have speech production, this is called dysphonia, or abnormal speech production, and difficulty with swallowing, dysphagia. All right, the last thing here is that what if we also don't get enough stimulation to this last cranial nerve nuclei here, which is going to be called the hypoglossal nucleus, or the hypoglossal nerve. This one is involved also with tongue movement. So what can happen is they can develop a spastic tongue, and it can lead to their speech being very abnormal in articulation. And so this can lead to what's called dysarthria. Okay, so again, with this Pontine Myelinolysis or Osmotic Demyelination Syndrome, not only can they get some of these cranial nerve nuclei, particularly the fascicles of them, getting demyelinated, but you can also get the pseudobulbar palsy with demyelinating the corticobulbar tracts. So again, corticobulbar tracts getting demyelinated, but particularly the fascicles, the fibers that are coming out from the cranial nerve nuclei within the pons, those are getting demyelinated. Okay, good. We covered those. The next thing, so we got corticobulbar tracts. We have the fascicles, or the fibers of the cranial nerve nuclei within, or the cranial nerves inside of the pons. The next thing is the fibers of the tracts that run from the cortex down to the spinal cord. What are these? So if we were to imagine here, again, we're looking at like the primary motor cortex. These give these neurons that run down via the corona radiata, and then they run through the midbrain, they run through the pons, and as they get down to the medulla or on the pyramids, they cross. They decussate, right? And then eventually they'll go down to your lower motor neurons, and these will go out to the muscles of the extremities. Now, what happens is there's usually lesions that develop within the pons. So what's going to happen is as these fibers run through the pons, you can knock both of these out potentially. If you knock both of these out, what could be the devastating effect out of this? Significant weakness, and worst case, paralysis. And it can actually be as severe or less severe, I mean it's both terrible, but paraparesis, where maybe only like the lower extremities are weak or completely pelagic. Worst case scenario, if you knock out a good chunk of those corticospinal tracts, you're knocking out the complete supply to both extremities, uppers and lowers, and this could lead to quadriparesis. Okay, the next thing that I want you to remember, so we hit fascicles of the cranial nerves, 5, 6, 7, 8. We hit pseudobulbar palsy, we hit corticospinal tract lesion. The next thing, which is actually kind of the sad and kind of one of the more devastating effects of this, is in the pons, and extending throughout the brainstem really, there's a structure here called the reticular formation. Now, the reticular formation is so important because it's basically the arousal or the alert center of kind of our central nervous system. You know, any sensory information that's coming into the body. For example, we have sensation that's coming from our eye. So when we visually see things, it goes to our retina, goes to the optic nerve, and eventually goes to the reticular formation. From the reticular formation, he'll send it to the cerebral cortex. If we have a sensation, if someone touches our arm, we're eventually aware of that sensation because it'll make its way to the reticular formation. So it's receiving this constant sensation, whether it be visual, auditory, some type of somatic sensory stimuli. From that, it'll sift through it and say, this is the most important sensory stimuli that we need to think about, sends it to the thalamus. From the thalamus, it'll send these radiations throughout the entire cerebral cortex, alerting us, arousing us of the most important sensory stimuli that we are completely experiencing. If, in this sad case of central Pontine Myelinolysis or Osmotic Demyelination Syndrome, you knock out some of those white matter fibers that are present within the reticular formation, you alter the sensory information that we receive. And so your level of consciousness and your overall state of kind of understanding and arousal is declined. And so you potentially develop this decreased level of consciousness or decreased level of arousal. And worst case scenario, this can cause, if someone develops quadriparesis, they also develop diplopia, they develop all of these problematic issues, and on top of that, you take out the reticular formation, there's a chance of developing a condition called locked-in syndrome. Okay, and so this is something to be thinking about, where this is not technically a comatose state, but the person is literally locked into this quadriplegic state. They have no ability to really show facial expressions. All they can really do is just kind of move their eyes up and down and kind of communicating with you. So it's a really sad condition. All right. The next thing that we have to talk about is diagnosis. So when we're diagnosing central Pontine Myelinolysis or Osmotic Demyelination Syndrome, okay, synonyms there, again, you have to remember, okay, someone had chronic hyponatremia. You quickly reverse that way faster than you should have, okay, because they had time to adapt, and then when you gave them a punch of different salt, they didn't have time to adapt to that, and so you caused this damage, this shrinking of the cells, this demyelination type of effect. Symptoms that usually develop, the cranial nerves, particularly within the pons, get affected, the corticobulbar tracts, the corticospinal tracts, and the reticular formation get knocked out. Usually those symptoms appear about 2 to 6 days after the actual demyelination or event. The next thing is whenever you have this patient who presents with some of these symptoms and you suspect osmotic demyelination, they ask you on an exam, what is the first line diagnostic test? You say MRI. So in this situation, I want to obtain an MRI. And we should do the brain. Primarily, you can extend it to the spinal cord, but really it's an MRI of the brain. Now, when we do this, what's really important about this is you can do it with and without contrast. So you can do this with and without contrast. But one of the things is that whenever you obtain an MRI on a patient with Osmotic Demyelination Syndrome, it may not show up acutely once you think that, oh, this person has osmotic demyelination. I'm going to get an MRI. It's going to show up as these highlights, these white signs on a T2 part of the MRI. Sometimes these signs of demyelination don't show up for almost 2 to 4 weeks after the initial injury. So sometimes if you get an initial MRI and it appears normal, you need to get a repeat one in about 2 to 4 weeks because it does not exclude the diagnosis, okay? So remember that. You may need to repeat in 2 to 4 weeks just because it does not show up on the actual MRI does not mean that it is not still this condition. So where would it affect? Primarily, this lesion likes to involve, the lesions that you'll see is going to be involving the pons. Now, we didn't talk about this, but sometimes lesions can extend into other areas, like lesions involving the basal ganglia. So sometimes you can get some abnormal motor movements potentially. But sometimes it can extend to the basal ganglia, it can extend to the midbrain as well. So you could get extra pontine lesions. But what we're looking at when we get the MRI is you have 2 components. You have a T1, you have a T2, and then you can look at the component after you give contrast. Generally, when the T1 image, sometimes you may see these hypo-intense lesions that will pop up, meaning that they kind of show up dark on the image. And then when you obtain the T2, particularly the T2 flare image, this may show up hyper intense. And this will show up kind of like bright on the actual MRI. And again, be looking primarily in that pontine region, but sometimes it can extend into other areas. And the last thing is contrast. Generally, when the contrast is actually given, it may highlight on the T1 post that there's actually more of an acute lesion present. So it may actually enhance the acute lesion, which again, this is pretty much an acute condition. So it'll enhance those acute lesions that you'll see within the pons. Now, the other thing that should aid in your diagnosis, because if someone presents with these symptoms, it doesn't necessarily always point, oh, this is osmotic demyelination syndrome. Think about the context. Look at their chart and say, okay, they came in with a sodium of, let's say they came in with a sodium of 110. Okay, that was their initial sodium. Then what you decided to do is give them a ton of salt over the period of like a day or two. And you increased their sodium dramatically up to 145 all of a sudden. You went from 110 to 145 within a day or two. That is a drastic change. So when you see this extensive increase in sodium, particularly greater than 6 to 8 milliequivalents per liter in a 24 to 48 hour period. Particularly, actually, we should even be more stringent and not say 48 hours. We should actually say 24 hours. If you correct the sodium that quickly, greater than that amount, in a short amount of time, it's going to lead to this osmotic demyelination and a chronic hyponatremic. Okay, so think about your image and correlate it with their underlying sodium and how you've adjusted that. All right, so let's talk about the treatment of osmotic demyelination syndrome, or again, central Pontine Myelinolysis. So we've come to the diagnosis. We had someone who was a chronic hyponatremic. We reversed their sodium too quickly. They developed these clinical symptoms that we see above. We see it on an MRI, maybe initially, maybe 2 to 4 weeks later, and we notice that their sodium was way too quickly, rapidly reversed, greater than 6 to 8 milliequivalents per liter in a 24-hour period. And you say, dang it, how do I treat this? Well, unfortunately, this is more of a supportive condition. There's no reversal, there's no antidote, there's no oh, you do this and you can fix it or stop it. No, unfortunately, it's supportive therapy. Because these individuals have that high risk of kind of aspirating, and because of that, we want to reduce the risk of aspiration pneumonia. As well as, think about this, what was that one structure that we could potentially hit? The reticular formation, so there's a declining level of consciousness and potentially the ability to not protect their own airway. And so because of that, this may require endotracheal tube intubation for a period of time, maybe 6 to 8 weeks. But generally, you don't want to have an endotracheal tube in somebody so long. So eventually what may happen is you may go from an endotracheal tube to a trach. Okay, so you'll do a tracheotomy, and then hopefully over time, they'll be able to breathe on their own, that you can remove that. That's the goal over a 6 to 8 week time period. The other thing is, because they're also going to have this decreased ability to be able to protect their own airway, and they're also going to have dysphagia, difficulty swallowing, we also need to give them nutrients. Unfortunately, they won't be able to eat their own food. We're probably going to have to do this via an NG tube and give them nutrition. But over time, that NG tube, we're going to have to transition into potentially a PEG tube, all right, a percutaneous endoscopic gastrostomy, where we put a tube in there to feed them straight into the stomach, and eventually we can pull that tube once they've potentially recovered over a 6 to 8 week period. Okay, the next thing to think about is not only are these the two big supportive therapies for reducing the risk of aspiration pneumonia, as well as in individuals who are going to have dysphagia, we're going to kind of do these two therapies. But the other thing is, try to slowly, and I mean slowly, recorrect the sodium. So if that person's sodium, let's go back to what we had before. If we had a person who had a sodium at 110, okay, so that was their initial sodium, okay? And they went all the way up to 145. Generally, the goal is to bring the sodium down nice and slowly, right? Maybe you bring it down to 134, and then maybe you'll bring it down to 120. And that's kind of the goal there. is to pretty much slowly recorrect the sodium to make sure that it's less than 16 above whatever the initial sodium is. So your desire is to kind of lower it down to where it's less than or equal to 16 above initial sodium. So the initial sodium was 110, we lowered it to 120, that is less than 16, that's only 10 difference. That's less than 16 above the initial sodium. That is the other thing that we're going to do, okay? So support their airway endotracheal tube, potentially extend to a trach, NG tube for nutrition, and then eventually you may have to extend that to a PEG. Hopefully over a 6 to 8 week period, you can remove those and they'll be able to do this on their own. We're slowly recorrect the sodium, and then prevention. Make sure that whenever you see a chronic hyponatremic, a person who's probably within a 48-hour period or greater, recorrected or adapted their actual astrocytes in a way that they've helped to create a extracellular, intracellular environment that somewhat has an equilibrium, do not correct their sodium too quick. What's the numbers that you want to go by? Do not correct for greater than or equal to 6 to 8 milliequivalents per liter in 24 hours. In what kind of patients? Again, in patients who are chronic hyponatremics. If you had someone who came in and they were hyponatremic for some other reason and it was less than 48 hours, maybe it was only a couple hours, you don't have to worry about quickly reversing or bringing their sodium up. It's about those individuals who have chronic hyponatremia that you do not want to quickly reverse it. And that covers osmotic demyelination syndrome.